Good evening. We shall be dealing with ECG case number 4 in our ECG series. The title of this ECG is Stairway to Heaven or Highway to Hell. If you follow music, you'll know that Stairway to Heaven is by the band Led Zeppelin and Highway to Hell is by AC/DC. So let's go straight to the case. This is a story of a 70-year-old female who had a recent anterior MI, which was thrombolized, and she was subsequently discharged. At a discharge, her EFS found to be around 32%, which is around moderate LV dysfunction. And she was discharged on DAPT, which is dual antiplatelets, beta blockers, enalapril, spironolactone, and now she's brought to the ER with severe fatigue. Her BP is on the lower side around 90/60, and her past history is significant in that she's an epileptic and she's on long-term phenytoin. So to summarize, you have a elderly female with recent anterior wall MI and moderate LV dysfunction on optimal medical management, and now she's brought you with a lower BP and she's an epileptic on phenytoin. So this was the ECG which the physician on duty in the ER saw. So it's a very frightening ECG, and this is an ECG which you might occur commonly in your clinical practice, especially if you work in a very busy institution. So what do? You find a white complex rhythm running around here. So what do? You give option A, you give amiodarone. Option B, you give lignocaine. Option C, you give DC shock. Option D, I don't know what's going on here, so I'll call the cardiologist. Let him decide what to do. Option E, okay, let's chill out and we'll wait for all the investigations. So we'll do masterly inactivity till then. So you can pause the video if you require further time, or we'll move ahead. So what did the ER physician do? The diagnosis he made was it was a ventricular tachycardia. Now, this is a very common diagnosis. This patient had a recently an MI and probably could have some monomorphic VT from a scar which occurred due to the MI. And she was given amiodarone bolus, but that failed to revert the rhythm, so she was given lignocaine. That too failed, and she was given procainamide. Now, just after giving procainamide, this rhythm occurred. Now, on seeing ventricular fibrillation, DC shock and CPR was initiated. But even after multiple DC shocks and cycles of CPR, she ultimately succumbed to her illness and expired. So what was the cause of death? So the cause of death was refractory VT leading to VF. Now, is this a true cause of death, or is there some other cause of death which you are likely have missed? So as usual, the lab investigations come in late. They came 2 hours after death. We showed a urea of 98, a creatinine of 4.11, and a potassium of 9.1. Now this patient has severe hyperkalemia. We are not aware whether the creatinine of the pre-existing baseline creatinine, but since she was on enalapril, it's fair to say that she had only, at the most, a mild renal dysfunction. So since she has a significant renal worsening on exposure to ACE inhibitor, this would further, if she was alive, you'd probably have to look in for bilateral renal artery stenosis. So this ECG actually shows what called as a sine wave pattern. Before we go to the sine wave pattern, just have a look at the extremely wide QRS complex. In a routine VT, your QRS complex seldom exceeds more than 200 milliseconds. So if you have a really wide QRS complex or an extremely wide QRS complex, you think of two differentials. One is a toxic and one is a metabolic. And metabolic, it's hyperkalemia. And two is, actually, if you look, there is no tachycardia by definition. The heart rate is around 80 per minute. So in a VT, your heart rate is always more than 130 per minute. Now there is an entity called slow VT. However, if you diagnose slow VT, you always consider whether it could be toxic or metabolic. Now what is the sine wave pattern? A sine wave or sinusoid is a mathematical curve that describes a smooth periodic oscillation. It consists of a merging of the QRS and T wave. You can see a clear merging of the QRS and T wave. We don't know where the QRS ends or the T wave starts. And it's a terminal rhythm. A sine wave often precedes ventricular fibrillation or asystole. So if you've seen this ECG, you know the patient is almost on her way out. So to summarize, an extremely wide QRS complex is rare in a VT. If present, you think of toxins, sodium channel blocker overdose, like tricyclic antidepressant overdose, or metabolic, which is hyperkalemia. VTAC usually has a fast ventricular rate more than 130 per minute. When you diagnose slow VT, you think of metabolic causes again. So hyperkalemia inactivates the sodium channels, or as some people say, hyperkalemia poisons the sodium channels. So what you can see here is the cardiac action potential. Minus 90 is your resting membrane potential. This is very important. The degree of activation of sodium channel depends upon the resting membrane potential. The more negative the resting membrane potential is, the more sodium channels are activated. So for example, if the resting membrane potential was say minus 120, you would have more sodium channels being activated than when it was minus 90. So what hyperkalemia does is it elevates the resting membrane potential. So say minus 90 becomes minus 75. So that less sodium channels are activated or more sodium channels are inactivated. So hyperkalemia inactivates the sodium channels, or you can say that hyperkalemia also blocks the sodium channels. So what caused the death of this patient? Obviously, it is hyperkalemia. There's no doubt about it. A potassium of 9.1 is almost incompatible with life, and a sine wave pattern is almost a terminal rhythm indicating the patient is almost is on her way out. Now, exposure to drugs which cause sodium channel blockade. Remember, the patient was already on phenytoin, which is a sodium channel blocker, amiodarone, which has multiple mechanisms of anti-arrhythmicity, one of which is a sodium channel blockade. Lignocaine and procainamide, both are sodium channel blockers. So although hyperkalemia was the chief cause of death, the sodium channel blockers certainly did not help and hastened her way out. Again, the last two are misdiagnosis and over-aggressive doctor. So we seldom as doctors admit our mistakes. We find very difficult to admit our mistakes, especially in public. This was a clear misdiagnosis, and when we try several things to save the life of the patient. Sometimes it might be successful, sometimes it might not be successful. So when a plan of management is not working, either you change your plan of management or you consult a senior colleague. This would have probably say if you have diagnosed hyperkalemia in this case, if a senior colleague had seen it and prevented the patient from going upstairs or downstairs. Hence the title of this presentation. So to summarize, what are your take-home messages? VT with an extremely wide QRS complex, you think of hyperkalemia. Slow VT, think of toxic or metabolic causes. A trial of calcium gluconate may be life-saving. In a tachyarrhythmia or a bradyarrhythmia, if you are suspecting hyperkalemia in appropriate clinical background, for example, a known renal patient who's missed a cycle of dialysis, presents to you with a broad complex rhythm, a trial of calcium gluconate may be life-saving. Nothing is going to happen if you give calcium gluconate to such a patient. So you at an empirical dose of say 10 ml of calcium gluconate might revert the rhythm completely and you can save a life of the patient. Last is avoid amiodarone and sodium channel blockers in hyperkalemia. In a broad complex rhythm, we have a reflex action to give amiodarone. Even if we don't know the rhythm, what it is, it's just a broad complex rhythm, give amiodarone for the patient. Now, that is a wrong concept, and amiodarone should only be reserved once you know what the rhythm is and once you are confident that this patient does not have any toxic or metabolic causes which could be worsened by amiodarone, as in this case. So lastly, learn from the mistakes of others. You don't live long enough to make them all yourself. So please like, share, and subscribe, and press the bell icon to get notified when a new video uploads. So thank you.